first.
It's disabled it.
Oh, okay. Sorry about that. Let's just see here. Okay. Let's see. Okay, so maybe we will take a couple of questions while we kind of figure that out. That's something we could do. So are you okay with that?
Yes, absolutely.
Okay, okay. So why don't we go ahead with our first question for today? So let's see. Okay, so the first question is, when a patient has a CCM in the pons area of the brain, is presently asymptomatic and an annual MRI has been recommended, is it better to be followed by a neurosurgeon or a neurologist?
Good question. So I think I had just 4 or 5 slides in it today, and one of them was about this PONS, because this is something that impacts our patients and community. So to answer the question, I think getting an MRI initially annually is a great thing to do. And then the main thing that kind of defines on who should follow is really based on the symptoms. So if it's completely asymptomatic, like truly asymptomatic, that the patient does not have any focal symptoms like double vision, dizziness type of things, then it's, typically a neurologist can follow the patient. Now, it also depends. My experience has been, even in the US, that most of the neurologists were not comfortable or were not aware enough about CCMs or cavernomas. So wherever the expertise was available, it was mostly the neurosurgeons. So it really depends. You need to, wherever you're living, it just depends that the person, whether it's a neurologist or a neurosurgeon, whoever's following you, are they aware? Do you feel comfortable and confident, in their expertise? And they feel comfortable and confident when they are engaging with you and they're answering your questions. So really, the role of neurosurgeons comes in when there's a symptom, because neurosurgeons are really good with surgical procedures. Now, I would say that some of the surgeons I work with and I learned from, they run cavernoma clinics, and they're very good at cavernomas. A lot of the times, neurologists are not even involved, and the neurosurgeons see the patients, decide about conservative management versus surgical management. So it really depends on the expertise level and person to person. And again, a neurologist can easily follow an asymptomatic patient, and that's how ideally Center of Excellence programs are built, like in the US.
Okay, wonderful. Yeah, thank you so much for sharing that. And I don't know if you're able to share on your screen now. We think we may have been able to fix that access issue. Yay, there we go. Awesome.
All right, can you see it?
Yes, we can see it. Thank you.
Wonderful. So really, it's just like 4 or 5 slides that may be able to touch upon some of the questions that will be coming my way. Again, before I start, I would say that, as a neurologist, when I trained at the Cleveland Clinic, especially in vascular strokes, cavernomas, AVMs, malformations, I only saw probably a dozen cavernoma patients with cavernomas, and similarly, other rare diseases were not that frequently seen. So my aim really, when I went to UNM School of Medicine as a stroke director there, New Mexico is a place where, based on the population, we have the highest number of patients with cavernomas there. So I've seen like probably more than 300-400 or 200 encounters in cavernomas, just because of being there, both inpatient and outpatient, during my time. And one of the most fascinating things I learned, which most of us doctors don't kind of experience, was this collaboration between Angioma Alliance, which was what it was called at that time, and physicians working together. And then we were lobbying and advocating at the federal and the state level. So a lot of my learning is really face-to-face working with the patients and hearing from them, learning from them what really happened. So that's why I was really excited when Prima got in touch and then we started talking. So this is something that I really value. So please feel free to be engaged, as engaging as you want, ask as many questions, and you'll find this encounter to be hopefully useful and valuable for yourself and family members or others. So by the end of these slides, I think the goal is, can I make you feel more empowered, more in control of the cavernomas that if you're living with them, that's pretty much the goal. So all right, so this is my first connection with you, and just to let you know that there's no conflict of interest, no financial or otherwise. So out of the 3-4 slides, the first one is this. So there are 2 types of cavernomas. In Canada so far, I've seen quite a few of sporadic cavernoma patients as well. But obviously, majority of the patients are familial. In my prior experience, obviously 99% of the patients were familial. That's where in New Mexico, the cavernoma, the CCM3 type was prevalent. CCM1 was prevalent, and we had CCM1, some CCM3 patients. Sporadic cavernomas are typically very benign, but sometimes they do end up bleeding. And then that's, when patients figure out that we have cavernoma, and then they start seeking medical attention. So the lesion on the right here is the sporadic one, just one isolated lesion. A lot of the times it's associated with what we call a venous anomaly. So that's kind of a typical pattern or picture. On the left, you see the cavernous malformation familial type, where you see multiple cavernomas, mixed, small, large, medium-sized. So the second thing that I get asked about is, what will happen? Am I living, like I have a time bomb in my head? Or if patients don't say that, at least I can feel that they think like that, and that's the fear they're living with. So that's why I wanted to kind of talk a little bit about it, is really to answer the question, whether a lesion has bled in the past or not bled in the past or never bled in the past, really defines on how the lesions overall in your brain would behave. So that's kind of one of the predictors. I will tell you, I've had patients who have had more than 100 cavernomas, sometimes 200-300 small cavernomas, mid-sized cavernomas, sometimes large lesions in the brain. And they never had any hospitalizations because of the cavernomas. And I've had patients who had 3 familial types, 3 cavernomas in their brain. One of them bled when they were a kid, or they were a teenager, or they were in their 20s, 30s. And then, we approach those patients a little bit differently because you would observe them more. The chances that specific lesion or some other lesions may bleed again in the future, the risk does go up a little bit. So that's pretty much answers the question. So if you have never had any bleeding, your lesions are, have been identified, you've been kind of told that, wow, you have these lesions in your brain, but none of them really had a symptomatic bleed, you would see us really reassure you that the chances that it's going to misbehave again would be extremely low. Just to kind of add a little bit on this as well, when we were in Albuquerque, Santa Fe area, New Mexico, again, thousands of patients had cavernomas there. The state had a population of about 2 million. And when we were advocating for all this, one of the advocacy was that should we get ICD-10 separate code rather than just a vascular malformation where AVMs and other lesions would be in there, or we were asking for some funding, so that all families with cavernomas can get free genetic testing done in their family members. Initially, there was some resistance, right? They were like, if we would fund you, the federal or the state government or the public health agencies, then other rare disease families or patients would come in and they would say that we need to be funded. So obviously the first step was collecting the data and then showing them what the data shows and the patient population that we had over there. So one of the challenges actually that kind of came in the way was that when we collected this large pool of patient data, we found that the disability was in a minority of patients. So although it was a fortunate thing, it is a great thing, but that was one of the reasons how and why the success in accomplishing a lot of those funding and a lot of those other avenues was less, because there were hundreds of patients with cavernomas, but the ones who really had a bleed or had complications was the number was really low. So something that may reassure you, if you are kind of worried about it all the time.
Definitely. That's good information to know.
So this pretty much, I think, is the last one, but so deep versus not deep, right? So the ponds question that was asked, really good question, is relevant here. So when we say deep, what we mean is, if you can see my mouse, this part of the brain is really the superficial part. And then everything else, under this is deep. So this would even be deep. This for sure is deep. A lesion, if it was present kind of somewhere here, would be a non-deep lesion. But so what we really say is a basal ganglia, which is this part of the brain, and then the pons and the cerebellum, which is this part of the brain, or midbrain, pons, cerebellum, any part of the brain stem. So these are kind of considered as deep. Within the deep category, we know that the brain stem lesions are the ones that are the highest risk of oozing or leaking or hemorrhaging. This is kind of in the basal ganglia. So these lesions comparatively also can ooze compared to the very cortical lesions. But even these lesions, when you compare them to the deep pons lesions or the deepest lesions, these lesions are relatively less risky then. So it's pretty much going from the superficial to the deep part. Why it happens that way, we've still not been able to understand and explain that. But based on a lot of patients that we have followed up and we have published in various journals, pontine lesions do bleed more and misbehave more. Yeah, this is the last slide. So that's kind of, again, published in various literature now, that if you have familial or genetic cavernomas, then there's a chance 50 to 60% or more that you are living with some sort of headaches. 30% chance, 23 to 30% that you can have seizures. If I have a familial cavernoma, cognitive complaints are highly prevalent. This is something that, when I started and I was, seeing patients, I started raising this voice in our NIH and other executive committees, and we started doing some studies on it, and we did confirm and publish that for sure, if we see patients with multiple cavernomas in their brain, they do have multiple cognitive complaints, and they can range from just ability to think slow, memory problem, I can't process information that fast. When I have multitasking, I don't perform as well as I used to. Those type of things are definitely found. But we're still studying it. We're still, reviewing data, collecting data from patients. So we don't precisely know, but it certainly is a large number. Anecdotally, I would say more than 50%. And then the focal deficit or bleed is less than or approximately 3%. Now, obviously, in that small group of patients who have had this bleeding, within those patients, the chances that they're going to rebleed does go up. So it does become more than 3%. But typically, of all the cavernoma patients, the bleed is 3%. Now, just to give you a comparative analysis, when we are doing procedures, surgeries, cardiac catheterizations, brain procedures, aneurysm repairs, even different abdominal surgeries, the risk of complications and disability and death actually is approximately 3% in pretty much most of those surgeries. So in the healthcare field, this complication rate is considered kind of relatively low. But obviously, when we're living with cavernomas, the fear that, oh, will I be the one? I can completely understand. But if this helps, the focal bleeding incidence is relatively low in patients with cavernomas. So the last part, and then I'll open up to questions, is so how to feel more empowered or more in control as a patient living with CCM, right? What have I learned from patients who have done well? So I've seen patients with more than 100 cavernomas working as executives in C-suites in banks. And I've seen patients with 3 cavernomas who then felt so bad that they had to, file for disability, and not being able to enjoy their life or go for camping with their grandkids or with their kids. So I've seen it, and what I've learned is these few things. Folks who know about CCMs understand about things, pretty much a lot of what I've already discussed, but some more, as you'll ask more questions. That's pretty much the number one thing. The more you know, the more empowered you feel, the less threatened you feel from this syndrome and from this disease, and the more control you keep. The second is working on cognitive skills. Learning a lot about it. Most of the people, if I was not a neurologist, I wouldn't know. If I ask my family members, they don't know what I'm seeing when I see it work on cognitive skills. But if you have cavernomas, I would encourage you to read about it. What does cognitive skills mean? What does cognitive therapy means? What is meditation? How can you really have good emotional intelligence? How can you control your emotions? A lot of people, and now there's published studies that when you exercise 20 to 30 minutes a day with a little bit of sweating, your cognition gets better. So some of this stuff, when you start reading about it, you will feel empowered. Okay, I'm taking control of my cognition. And in spite of the cavernoma slowing you down a little bit, you will still be in control. That's really the name of the game here. The other thing is be in the top 5% of the healthiest individuals. So that should be your goal. Very hard to achieve, but when you have cavernomas and you have a genetic, especially the familial type, then we really need to have an excellent diet, lifestyle, education about health, exercise regimen. And the last one is, with all the good stuff you'll do, you still need to know your limitations, and you'll learn them, and you'll trust your guts, you'll trust your body, and then you'll learn when to stop, and otherwise you'll overwhelm yourself if you keep fighting. And if you see something like that, then speak with your physician, tell them this, and that's where the physicians or the neurologists, neurosurgeons know about cavernoma will obviously say, okay, I completely get what you're saying. This is a time where you need to change your job and do those type of things. And I've already had few patients here in Canada whose life has been changed just by learning some of these things, adjusting, modifying, and then getting their quality of life back. And that's pretty much it.
That's excellent information. Thank you so much. I so appreciate that. I'm sure so many of our people attending can really relate to that information and stuff. Thank you so much. So we'll go back to our questions that we have from our patients. So kind of talking a little bit about what you just talked about. Do you have any thoughts as to what exercise regimens may be safe for patients with CCM? And also, is the location of their CCMs of any relevance to how they go about exercising or how much they exercise related to this?
Excellent question. So I will share this disclosure that we don't have a lot of evidence. So the answer is not truly evidence-based. We haven't been able to. Exercise is such a subjective, tolerance-based thing that we haven't been really able to clearly delineate what type of exercises and build protocols or guidelines around it. But I'll share with you 3 things that may help you kind of get the answer. Number one, I had a couple of patients who loved scuba diving and they had cavernomas. High functioning people would travel all over the world, go to the Philippines for scuba diving, things like that. So when we all started and they got the diagnosis, I would freak out and I would tell them, I've learned this, that you shouldn't go scuba dive. You can snorkel, the pressure changes are too much. I wouldn't suggest you do that. But then they wanted to maintain their quality of life. Both of them ended up doing it. So they continued to do it. They would go deep down, multiple feet, 12, 15 feet in, And I kept on following them up and seeing them. And for the next 3 years, while they continued their aggressive scuba diving, they never had any oozing, bleeding. And I was freaking out. Instead of getting an MRI once a year, every time they would come back from their trip, 3 months later, I would do another MRI because I was like, I don't know if it bled or not, but I never saw any. So anecdotally, I felt much more reassured. Same with, we saw some patients from different parts of like Colorado, California would fly in, see us once a year in our clinics. Some of them were football players or impact, sports, and we would do the same. Don't do it because that's what we've been told. You need to be cautious. But they were young people. A lot of them were in their early 20s, and they would still do it. So we'll do the same thing. We'll freak out. We'll do the MRIs and stuff, but we didn't see anything. Anecdotal, but data of about a dozen patients, and we didn't find anything. So just to kind of give you an idea. The second point I wanted to share is what we ended up doing is we ended up doing some angiograms, and Dr. Isam Awad in Chicago, who's one of my mentors and one of the big names in the world of cavernoma, in the 90s when I was, not even a medical student, I think he was doing some studies at that time where he was injecting or doing an angiogram in cavernoma patients. So what we found is that even if your blood pressures are really, really high, and even if we are injecting high pressure contrast into the brain, we didn't find that there were any changes in the walls of the capillaries in the cavernoma, which a lot of people, us don't, kind of think that way. So, but that information helps us quite a bit. So I've had patients with cavernomas who were diagnosed with cavernomas incidentally. They came in with hypertensive emergencies because their blood pressures were high. And we obviously observed their cavernomas in detail, but we never saw any misbehavior in the cavernomas. So that's kind of the reassuring part. So now to the third part, which is the exercise. I will tell you that meditation in combination with 20 to 30 minutes of exercise that keeps your heart rate around 120 to 140, but enough to make you sweat a little bit, is the best. So if you can meditate for 10 minutes and then another 20 minutes, do some sort of a cardiovascular jogging, running, light weightlifting, brisk walking. If you have arthritis, then hand cycling, something that would raise your heart to 120 to 140, and then you sweat a little bit. I've seen this work really like a charm. And some of my patients were on a wheelchair, and then we worked together on physiotherapy after a cavernoma misbehavior in their pons. And then I found them to be able to walk again and do really well. So those would be the 3 points, if that helps.
That's excellent information. Thank you so much. So another question we have from a member is, does air travel, diving, which you just talked about, or the impact of a fall pose an increased risk to having a seizure or a bleed? What are your thoughts?
Great. You'll see that a lot of the things I mentioned, because I pretty much have interacted with hundreds of patients with cavernomas. So I pretty much discussed this, right? So if you have that we don't think that there's any impact of flight. So regular flights, we've had multiple patients doing international across the continental flights, and we allow it. It happens without any problem, and that's clear. We still don't know about Mars, whether going into space would make a difference. I think it will happen in our lifetime. So I think that would be interesting to see, because the pressure changes are too much. I think some of my patients who ended up scuba diving, they went down to 10, 12 feet, and they used to do it even deeper. And because of the cavernomas, they did limit it based on our request and on when I was really asking them not to. So I think that definitely played a role. I did scuba dive in the past, so I completely understand how it feels when you're deeper in. It is a lot of pressure changes. So I think 10 feet, 6 feet, that's pretty much a good scuba diving number. Air flights, international flights, all of that is completely fine. And snorkeling and all those things are completely fine. Impact, trauma, as I said, I've had patients with concussion, young folks with concussion, haven't had any issues. Now, if you talk about repeated concussions, it would be a different ball game. So if you're in some sort of a lifestyle or boxing or something, then we normally ask you not to do that. Because repeated concussions with the way the capillaries would shake, that can put you at risk.
Okay, great information. And if we happen to know a CCM patient that does go to Mars or the moon, we're going to need to talk to them, or you're going to need to, for sure. Okay, so the next one we have is a thank you plus a next question is there an opportunity for Canada to have a center of excellence?
We would love to. So this is one of my dreams as well. Preem and I have spoken about it. We are in touch with sick kids, and we want to create one where virtually and we build a virtual program and an in-person program, and then build satellite partnerships with regional centers eventually. I think in my mind the timeline is 12 to 18 months. And I think our volume of patients is not as much to kind of get support from the hospital systems. So it's all voluntary kind of work, but I do feel like that we at least need one CCM Center of Excellence for sure. I will say that because Canada is closer to the European Union than, interestingly, the US was, I feel. So I have started seeing patients actually who sometimes are like, a couple of them actually flew from Europe, like Switzerland and other places, to see us in Toronto. So I believe, although we have a lot of collaborators in England and Spain, but there is probably some need even in Europe. So we're looking forward to it, and hopefully in the next 12 to 18 months, you'll have some good news.
That would be fantastic. We're looking forward to that. Okay, so what are your thoughts on the use of the medication amitriptyline for migraine prevention? This particular question, the person states that they've heard that some antidepressants may increase the risk of brain hemorrhage because they may thin the blood. So what's your thoughts on that?
Good question. I will say that this is something that we looked at very closely, because as just as in my slide I showed you, headache is the most common feature of patients with cavernoma. Nortriptyline, propranolol are the two most common medications that we use. Amitriptyline is just a little bit more symptomatic than nortriptyline in my experience, especially in cavernoma patients. I feel like patients with cavernoma are a little bit more sensitive to chemicals and medications. I don't know why, but so nortriptyline has less side effects. I've had at least 4 or 5 dozen patients with cavernomas on nortriptyline who did reasonably well. If anything, most of the patients who have bad headaches or severe headaches need 2 migraine medications rather than 1. When I was in the US, Aimovigs and those type of drugs were coming out, the CGRP receptors. So our group was actually working on trying Botox injections and cavernoma and Aimovigs, and we're trying to see if it would cause anything or any symptoms. So we consented patients and we started trialing it out. And we found that in our small case series that all of these drugs are safe. We don't see any increments in oozing. Now, there are certain antidepressants other than citalopram and Prozac, where I would say I don't have a lot of experience with. So some of the hearsay and reading that I've done on case reports, I do hear about that. That's the main reason why I don't use them a lot. So I have some medications that I've tried in patients with cavernomas. They've worked safely, and those are the ones I stick with. So nortriptyline, propranolol, verapamil, and then Aimovig, which is the strongest one, and then Botox injections. All of these we have tried on considerable, repeatedly, same patients, multiple patients for 2-3 years, and we've seen no problems at all.
Okay, great. No, thank you so much for that information. Is there a specific location of having a CCM in the brain that would be known to cause myoclonic twitches, like exaggerated hiccups in the case that this person's referring to? Have you seen myoclonus made worse by eating processed foods containing additives like MSG or yeast extract?
Excellent question again. So yes, I have seen patients. So what happens is there's normally location-based. So if there's a lesion in the brainstem, and it's changing its size or it's impacting the hiccup area, then we see it. I have seen patients with myoclonus in the body as well, hiccup being one of them, but in general, having shaking or myoclonus in the body. I normally, so there are some medications in general, and I had a couple of patients who were really tough, and they were referred to me from California. We ended up trying clonazepam, a controlled substance, but that's the one that worked really well. Yeah, combination of gabapentin and baclofen also works well in hiccups.
Okay.
So yes, it can happen. It's all based on where the lesion is, where the cavernoma is. So that kind of decides. I will say one other thing, because I didn't put it in the slide, but since there's so great questions coming in, I think it would be good for the folks to know, is this. So you hear about cavernomas, and then sometimes you get confused after you get an MRI or a CT scan, and the doctors tell you, it seems like it bled. And you're like, maybe 6 months ago when I had that symptom or hiccup or headache, maybe that's when it bled. And then, there's no right or wrong answer there. There's just confusion. So what we learned and what we started proposing was that we should use two different words. One is oozing and one is hemorrhage. Oozing is a phenomena that we know based on all the sophisticated MRIs that we were doing as screening on our research patients. We found that oozing happens every now and then. So when we do MRIs every now and then, you can be told that, this lesion looks different. There's some oozing around it. And that is not that lethal, dangerous, bad. It is going to be a little bit irritating because when the oozing happens, this brain tissue around that capillary will feel a little bit irritated. So wherever that lesion is, that brain part would cause some symptoms like numbness if it's on the left side, the right hand be numb, but then it will improve over time. And then that's why if you are really aware of what this might have been and not freak out about that little oozing, because that happens a lot. And this confusion about what was hemorrhage and what was oozing really confuses and then makes us worry about our lesions more. Hemorrhage is really where one of the capillary or one of the branches of the capillary burst and or ruptured, or the wall was not good enough that it really broke open and a lot of blood then leaked. That's when you have, okay, I will have my arm weak, or I'll have a significant facial droop, or I will have double vision. So that's kind of, I just wanted to put it out there that something that I didn't share on the slide.
That's really great. Thanks. I think that often that whole ooze versus bleed hemorrhage comes up in patients and their families really trying to understand that. And kind of on that similar topic is, often patients are looking to see when they should be going to the emergency room. Maybe a slight change in symptoms, or momentarily, or for, half an hour, they have a change in symptoms and they're kind of questioning, like, is this or isn't this a time when I should be going? Like, is this an emergency or should I be seen? Thoughts on that?
Yes, excellent question again. So I think I would put the answer in two ways. One would be if you've been all your life a completely asymptomatic patient, and you've never had, other than maybe some headaches, you've never had anything else, and you do your annual or every 2-3 years screening, and then you don't have any symptoms. Then if you have any focal neurological symptoms like the ones you described, that one arm is numb for no reason, and I don't know, it's not getting better, or my speech has now become slurred, or I'm having double vision, my balance is off, my speech is not the same, and I'm having difficulty expressing. So these are new neurological symptoms that are there, that you're not assuming, right? That are there, you can feel it, then you should go to the emergency room and get checked. Just for the first time, so that we know how your cavernoma or that cavernoma behaves. So maybe that hospital near you has a trial that they're participating in. Maybe there's a DBA close to the cavernoma. Who knows, you have a sporadic type. So there are different ways of managing in that acute setting. So knowing in that time is important. Now, if you've had symptoms before, if you've had cavernomas before, which had misbehaved or oozed or leaked, caused symptoms, irritating symptoms, then really you're not going to see a lot of difference when you go to the emergency room, other than the long waiting time and frustration that's going to add the extra stress. So in those situations, I normally say that unless you have a disabling symptom, because even in the worst case scenario, right? Even if they're in that rare situation when the cavernoma really bleeds and ruptures, not oozes, and now we're seeing a patient with significant disability, we end up admitting the patient to the ICU, but we still don't do anything emergently.
Mhm.
We manage the patient urgently. And in Canada, I've learned it's really not easy to get access. In the US, access was not that of a big deal. Insurance and then the bills coming to the patient's home was a big problem. In
Yeah.
Canada, I feel like access is a problem. So when I say emergency room, what I want to say is if you can get into your neurologist or neurosurgeon's clinic, or your family doctor can at least get a CT scan in the next 2, 3, 4 days,
Yeah.
then that's reasonable. Even in Toronto, I feel like getting that done as an outpatient is a tough ask. And a lot of times we end up asking patients, I don't think I'll be able to get these scans as an outpatient. Why don't you just go to the ED and get the scan done?
Yeah.
So it's all logistics. The ideal answer is no, you don't have to go through that inconvenience. But unfortunately, unless you have a good, system there where you can get scans in 3, 4 days urgently, then it's reasonable not to go for benign symptoms. If it's severe, then yes, go. And by severe, I mean, wow, my right hand is not working. My left hand, I can only wiggle my fingers. What happened there? That's significant, right?
Yeah.
Compared to I'm having some facial twitching, or I'm having some numbness in my hand, or yesterday I was able to grip the bottle pretty well. Today I'm having a hard time, but I can still do it.
Okay.
Those I'm saying that you can wait it out and get it in the next 3 to 5 days.
That's awesome. That actually provides a lot of clarity. Thank you so much for that. Can trauma to the head or spine cause a cavernoma to develop?
That's a great question. If you ask me, when we look at trials like the research-driven data, we would say it's possible,
Yeah.
and we do think it happens. But typically, the cavernomas, the sporadic cavernomas, are associated with a DVA in that area, which is a normal venous anomaly. That's a pretty typical that it was there when you were born, and it just evolved, or it was just stable and just misbehaved or didn't misbehave. So typically, multiple cavernomas, no. It's impossible for multiple cavernomas to develop after you had multiple traumas.
Okay, great information. Thank you so much. So is there anything to be said about unidentified genetic mutations being involved in CCMs? This individual has read a 2019 paper that you co-authored, talking about the existence of these are contested as opposed to it alternatively being a genomic inversion of CCM2, that's in quotations. But I wonder if there are any observed trends and characteristics among those with a family history of CCMs, yet whose genetic tests do not come up showing any of the 3 identified genetic mutations.
Yes, great question. So the answer is yes. So there are, we have had patients where we did a genetic panel, came back negative. So we waited for our funds to resume for that same patient next year, got it done again, and came back positive. So the false positive negative stuff, is something to consider. So if there's risk, then we do retest. And why it happens that way, we don't know. It's genetic. It should be pretty straightforward, very specific and sensitive, but it does happen rarely. Is it possible that there are a few patients who don't have CCM1, 2, or 3, and there's another rare type, which is playing a role? I personally believe yes, but we've done, I think I would say that 99% of the patients are captured, within the CCM1, 2, 3 genetic testing and then panel. But there's definitely a small minority of patients who have another type. Just to add one thing in there, so the sporadic type, where patients have mostly one lesion, or a mutational type where there's no family history and the patient ended up having, they were the first one who had the mutation and now it spontaneously came in. Also rare, but we've seen those, some of those patients. In those patients, the genetic panel often is also unpredictable, right? So can come back positive, can come back negative. So definitely there's some sneakiness to how these genes behave in a minority of patients, but in majority of the patients, we'll have either of the three types in our first set of tests. If it's negative, then at least in the second set of tests, we'll find one of them coming back positive.
Okay,
Does that
yeah,
answer the question?
yeah, I think it did. I think it did. Absolutely. Do you believe that having a high number of CCMs impacts patient symptoms even without having a hemorrhage?
Yes, actually, my group is working and finalizing one of the papers on this, and we have found even evidence, based on patient surveys and the volume analysis, that it does play a role. Now, obviously, the more CCMs we have, the chance that one of the lesions, especially a deeper one, is going to ooze at least, if not bleed, it goes up.
Yeah.
However, when we did our study and when we are looking at those numbers, again, it's not published yet, we didn't find that it was statistically significant as such. What it means is that it's not a high risk to have a lot of lesions. Many of the patients actually in New Mexico, the familial cavernoma family members we saw who had multiple lesions, even in like 80s and 90, plus lesion count, they were pretty good. They didn't have any, symptoms down the lane as we followed them up, up to like 7-8 years. They did pretty reasonably, they didn't have anything. So that's one part. The other part is it possible that they can have cognitive issues and headaches?
Yeah.
That we found, and we are finding in our study as well, that there's a pretty significant chance that you will have cognitive issues, if not now, then later on. So then preemptively staying on top of your cognitive health would be really important if you know that you have multiple lesions. Now, multiple lesions, when I say 20, 30, those are not a lot. When I say really multiple, it means like 70, 80 cavernomas or more than 50, 60. That's when cognitive and headache would be an issue.
Okay, great. So I think we have time for a couple more questions. Can you talk a little bit about lots of thank yous coming in? So thank you so much. You're really being so helpful to everyone and informative. Can you talk a bit about the risks associated with radiation to the brain, for instance, with gamma knife or for cancer treatments and the development of CCM?
Yeah. So, the radiation-induced cavernoma is a very well-known concept, in my clinic pretty much every 3 months, because we have Princess Margaret Hospital, that's a cancer center. So we do see patients with radiation-induced cavernomas. They can confuse us sometimes because they can look like familial cavernomas, behave like cavernomas. There could be one, there could be multiple. But obviously the history, the location where the tumor was resected or radiation was given, and then knowing the exact radiation oncology, description of where the probes were kept and how the radiation was given, and then finding cavernomas mostly in that direction or around that, gives us a clue and helps us diagnose. But yes, it plays a role. Radiations do. Just the basic gamma knife, it doesn't as much. There are case reports. It's really the heavy radiation. So if somebody has had a glioma or any other sort of tumor, neck, head, eye, facial, skin, and they got radiation there, then they can have it. Now, I apologize, I missed it, but was this question also asking about role of gamma knife in treatment?
In the development of
In the
CCMs.
development, right?
Yeah.
So yeah.
Yeah.
So yes, gamma knife, not so much, can play a role. Typical timeline, anywhere between 6 to 15 years is when that radiation-induced genetic mutation happens, and then that triggers the cavernoma. Typically not after 1, 2, 3 years. It's going to be 6 to 15 typically.
Well, that's very interesting information. Okay, so last question. We have lots of questions. We will save them, I promise everyone, for hopefully another time when we'll have Dr. Zafar with us. But so the sleep med Ambien, this individual says that they have heard that it's shown to help with brainstem injury post-cavernoma bleed in the pons. Does it need to be implemented soon after injury, or do you have a general opinion about the use of Ambien in this case?
You know, I am not a staunch supporter of any of the Ambien or Ambien class drugs. Uh, I know there was a case series and a discussion published on it and discussed about even in a conference. So the whole idea is that Ambien and Ambien-like drugs, including benzodiazepines, right, the anti-anxiety drugs and sleep drugs, what they do is they directly or indirectly are helping calm the deep part of the brain. So that's what their role is. And a lot of the sleep function, or what we call the reticular fibers that are present in the deep part of the brain, really keep us awake during the daytime. So that's really the natural way these drugs work. It calms those reticular fibers down, even in patients who don't have cavernomas or any lesion. And that's how they work in making us sleep, especially the benzos. So in cavernoma patients, obviously now they've had surgery or they have had a bleed. That part of the brain, the deep part of the brain, is now irritated, and there's a lot of irritation going on. So yes, Ambien or benzodiazepines, theoretically, we all know, would calm that area down. But in the long run, would it really help, or does it have really neuroplasticity effect? Either I'm not aware of it, but based on my understanding, experience, evaluation, reading, I normally do not like my patients to get dependent or use those medications. Now, the question about should I start it or should we have started it sooner if need be, I would say there's no irreversible problems or damage with it. So even if you're on it and you want to try it, I think it probably will symptomatically help us or help you in the initial few days post-operatively or after the acute bleeding, because it's just going to calm that area down until the brain heals and settles down. So that's pretty much what you'll be using it for. I'm not aware or really buy in with the data that's so far there that it really helps change in the long run neuroplasticity or helps us recover.
Okay, great. Thank you so much. We so appreciate your responses, all your such valuable thoughts and guidance on CCMs. And I can't thank you enough during this brain awareness time for us with the Angioma Alliance Canada and all of us trying to raise awareness on cavernous malformations. It's been so wonderful to have you here. We're so appreciative of it. This has been recorded, and we will also be starting our YouTube channel for Cavernous Angioma Canada, or Angioma Alliance Canada, sorry, very soon, and this will be posted on it as well. So thank you so much, Dr. Zafar. We really appreciate it, and have a really wonderful evening, everyone. It was really great to have everyone attend. Thank you so much.
Thanks for having me.
Thank you
Have a
so
good
much.
night.
Good night, everyone.